Good afternoon. Welcome to the ACCCN Institute of Continuing Education Advisory Panel webinar. Today we have Dr. Frances Lynn, who's from the Quality and Safety Advisory Panel, who's going to speak to us on change management, how clinicians manage the transition process of an ICU relocation. Okay, I'll hand over to you, Frances. Thank you.
Thank you, Di. Welcome everyone to the webinar. Today we're going to talk about change management, how clinicians manage the transition process of an ICU relocation. So this talk is a similar version of the one I did in the Adelaide ICE conference in 2015. My name is Frances Lin. I'm from Griffith University. I'm the program coordinator of the Master of Cricket Nursing. I'm also on the, like Di said, in the Australian College of Cricket Nurses Quality Advisory Panel. The objectives of today is at the end of this lecture, so you will be able to understand the concepts of change and transition, have an understanding of what factors impact on the transition process of the change to the workplace, and understand the importance of using change management models, and also be able to go and analyze what factors should be considered when relocating an intensive care unit. Firstly, let's think about the concepts of change and transition. So change is considered to be the outcome. So, you know, what's actually the change? It's kind of situational, and you can see change happening. You can see the visible events. For example, if you want to move a hospital, then it'll happen on the day that hospital gets relocated. However, transition is a process. It's the time people kind of how people prepare to go through the change process and adapt to the environment. So it's a much longer process than the actual change event, and it can extend from before to after the actual change. Examples of change in our work life, the intensive care nurse, can involve a workplace change, work environment change. For example, you might change your employer. You go to a different hospital for work, a different ICU, or the hospital gets relocated, it gets refurbished, or you get new technology, so it changes, the things around you where you work. Also, it could be change to the clinical practices. So about the way we do things. For example, we introduce different kind of equipment, dressings you use for patients' wounds, for example, so the way you look after patients. And also can be changed to service delivery. So what kind of service the hospital going to provide, if they add some new things to going to provide to patients, and also how they're going to deliver it, the way they deliver it. And also it could be changed to leadership and team compositions. For example, you're getting a new unit manager or a new educator, or for example, recently two Queensland children's services got merged into one ICU. So you have teams from two different kind of ICUs coming together. And this could be also relationship changes. For example, people get promoted to other positions, maybe your colleagues, bedside nurses, and someone's going to become your manager after the promotion, for example. So these are some of the examples for the change that occur in our day-to-day work. For the transition, it is about before, during, and after the change. So the time period can be quite long. And when we think about change, we need to think about how does change affect people in the workplace, and why we need to really think about how to manage it. So first thing for that is to understand the transition process. William Bridges published a book in 2009, the updated version. It's called Managing Transitions. So it proposes that change, when people go through change, there's three different stages people go through. So when people move through from knowing the change is going to happen to they're actually in the changed environment. So the first phase of that is to ending, losing, and then letting go. So people know something's going to change. and we have to kind of let it go because we can't stop it. So this is the process, the stage that people kind of try to understand the change itself, and would have some kind of really mixed emotions of liking it or disliking it, or being anxious about it. And the next phase, once people come to terms with that change, we can't stop it, it's going to happen, then it comes to a neutral zone. So this is the phase between the actual change happens, and they've already know, they can't stop it, so they've accepted that's going to change. So this period of time, the neutral zone, is actually a really important phase. You can, as managers or team leaders, you can use this process to actually really steer people's energy towards planning for the change, and then communicate the change properly. So during this stage, if you don't work with people very closely and then leave, majority of the staff in the dark, then that's going to be problematic. So people are going to get more anxious about it, and then they won't know what they're facing. So that's going to cause a lot of anxiety. So after the neutral zone, once the change actually happens and people move into this new beginning, so they really have to work with a new system, so that whatever the change is, so looking at what they have to do to work with the new environment, and then how they have to kind of how they monitor the new work process, make sure everything's working okay. So the change process in the workplace, in the hospital, it's not just like going to a hotel, you can turn a key and go in, everything works. Change in the complex organizations, it takes time. Even though you plan very well, you learn from others, you kind of plan according to your understanding of what change is. There will be still some period you need to be prepared that there will be unpredictable things that can happen. So it's just like moving into a new house. So you learn how to work with the environment and make sure everything works. And also with change, it could be you have mixed responses to this change, and people support you. There could be also people resist the change, and resistance to change is actually quite natural, because we all like the old way, of the comfort of the way we've been doing things. So you really have to evaluate the resistance and where it's coming from, and then you deal with that. So sometimes the resistance can be quite big. So why do people resist the change? There's a lot of reasons. This is just a picture I found from LinkedIn website. So it's really just about people, the structures and processes kind of being involved in a change process and how they interact. For example, if you look at on the right-hand side, former change experience, for ICU relocation, for example, if you have some staff member had, been through a ICU relocation process before, and it was a terrible one, the team, didn't work very well, things didn't work, whatever. And then, if they go through this process again in a new environment, they're not going to like it, and they're probably going to tell other people, this is going to be bad. So the former change experience can really impact on how people respond to a change if they're going to resist. And also on the left, if you look at bad communication strategy, for example, if people don't get the information you actually intend to deliver, and then that's going to cause a lot of anxiety, and a lot of rumor might fly around, and then people could resist to change. And we all perhaps have experience of some change is going to happen, and this always there's some kind of rumors flying around because of communication. So there's a lot of reasons why people resist the change, and as health workers, we really have to understand, when we kind of facing a change and look at, are there any factors that potentially could affect the way people respond to that change. So when we can't really stop the change, then we really have to plan for it. So for the management team to manage the change, you really should look at what Donna Beading proposed back in 1988 about the structures, processes, and outcomes. So you need to make sure you have the structures and processes in place to support the transition, so that we achieve the desired outcomes, which is patient safety, staff safety, patient happy and staff are happy. So what structures do we need to look at? So with change management, firstly, you need to have leadership support. So you have, people support you through this change, they're happy with it, and they being in the field and explicitly support your change. And also you need to have a change management expertise. This is quite often quite problematic for healthcare organizations, because a lot of managers are promoted from their professional roles, like from registered nurse, for example. So quite often people actually don't have, never had any change management training. So this is important when you recognize you're going through a major change. It's probably good to think about where you can get change management expertise. And also you need a dedicated team. Change management is very time consuming. It needs a lot of work and a lot of time. So you really need to have the dedicated team to manage change. And quite often we don't have the luxury in our work. If you look at intensive care services, if you're going to relocate a unit, I've spoken to a lot of people who are kind of managing hospital relocations recently, and I haven't met anyone who was kind of pulled offline saying, this managing the transition is all you do. Most people are still doing their normal role. They have the normal responsibility, plus they got to manage this major change, and that's a really huge challenge for the managers. So you really need to look at organizational support and look at if you could spend, dedicate a couple of days of your time, or you get extra staff to do your work, and then you can free yourself up to do and then manage the change process. Processes for managing change, including communication. So you need to make sure staff are getting the information about the relocation, about the change. So if you don't communicate, or if you try to communicate but the message didn't get to the staff members, then that's going to cause confusion or anxiety. And also you need to have processes in place to involve staff. So staff know you're interested in getting them on board, and you're interested in knowing if they want to be part of any working party. So you need to kind of bring people along with you while you're managing the change process. Not just yourself managing and make sure everything's done, you tell people it's done, let's move. So it's really just about, involve staff. And you also need to have a process to monitor the transition process. All of this, we will talk about it, how we do it, when I give you the example of the ICU relocation study. And also feedback. So you have a process of, if people have questions, they can go and they know where to go and ask for information. And also about, their attitude, staff members' attitude towards change, and their involvement, to make sure you give a regular feedback so people know they're doing the right thing. So those processes are really important. It's very time consuming too, but it's crucial for a successful transition. And also, in this whole of change management process, the outcome monitoring is the most important thing you need to consider, you need to plan. So make sure patients are safe and the staff are safe and happy to for this change. So you really need to analyze what are the outcomes, what are the patient safety indicators that we need to kind of consider to monitor. Say, for example, every month we need to look at what kind of clinical indicators to make sure that's all good. When it comes to change management, you really need to start with by thinking about what change management models you use. Change management models are, a lot of them are being tested in many different environments. So it can help you to really think about your change process and the process of managing the transition process, kind of do it systematically, so you don't kind of overlook any important aspects of the change. Say, I mentioned the bridges transitions model earlier, so that will help us to understand what emotions staff members might go through. And other change management models, including Coulter's 8 steps to change. So these 8 steps is not linear. You can say it goes step by step, but a lot of steps can overlap in the process of managing change. And there's also a Lewin's change management model, which he proposed this back in 1951, and people are still using it. It's about unfreeze. You start with unfreeze your current practice, and you're going to change, and then the actual change happens, and then you look at refreeze, going to ensures the change becomes permanent, and how to consolidate your practice. So these just are some examples of change management models, but there are many others. So that's why when you think about managing transitions of change project, you really need to think about where you can get change management expertise so you can do this properly. Strategies to manage change and transition from the models, they suggested there's many strategies you can use. So I found there's a little picture from the internet. I didn't really invent them myself. So the first one is managers. So you've got to tell your staff, acknowledge it's painful. It's very normal to not liking it, and then if you're feeling stressed or whatever, that's all quite normal. Explicitly acknowledge that's okay. It's quite important. And then you need to motivate people. So tell them why this change is important for us, and make sure they come with you. And with you can also use change champions. I just got a bit distracted with the question just popped up just then. You can use change champions. Choose some staff members who really support this change and who have the really good interpersonal skills to help you to be change champions, to lead something in the process to help you. And also communication. These days we're quite fortunate, like we have a lot of different methods to communicate with people. So find out how you can actually really communicate the intensive care relocation, how your staff can get your relocation message. Quite often, I think, a lot of hospitals communicate with staff members through workplace email, work email, and also the information on the hospital shared drive. And from our project, we learned that's really problematic because people don't have access to this the work email and the shared drive. And at work, how often a intensive care nurse would have time to go and check the email or to go and click through the shared drives? So they don't get the message. So make sure for this change project, you find a way that people can get your message. You may have to use a different method because people prefer different things using different methods. So you may like to establish a Facebook page if your hospital supports that strategy, or you print out hard copies and make sure people get a copy, or you record some important YouTube messages can be privately shared with your team. So you really have to make sure that people get the message and people can actually ask questions as well. You also need to involve all staff in your in the change management. Quite often we could be, as managers, you could be really kind of involved in managing it, but forget there's a lot of staff on the floor. They actually need to be part of it. That you need to engage them in the process. So make sure, ask people if anyone's interested in being part of any, certain aspects of the change management. And also you need to have this communication loop, have feedback. So it's about you asking for feedback from staff about how you're communicating, if your communication strategy is working, what information they need. It's also about giving feedback to staff about how they're working, through the process of the change process. So that's some of the strategies that in the literature support that you should use, really look at when you're managing the change. So for the team members, it's really important you understand what is going to change, and understand why this change is being implemented, and importantly, you understand how it will affect me, yourself, say for example, you may have to upskill yourself after this hospital gets relocated, because they're going to cater for more different patients. Or you might need to look at different ways to get to the hospital, and can you get there at 7 o'clock in the morning after a few transfers or whatever. So you really have to think about how it will affect you, and then think about the strategies to deal with it, to solve that problem. Then understand what you are expected to do in the process. Do you need to go for some further training, and for simulations, for orientation, all those things you need to understand and then do it. And being informed is quite important. Quite often we complain about, we're not, there's no information about this change, or there's no information about orientation. But instead of spreading those negative attitudes, go and seek information is really important, and ask questions, and ask the people who you think have the answers. And sometimes your manager might be really busy to answer your questions, but you really need to stop them sometimes and say, I really have this question, needs to be answered. So this is just about the kind of background information about change management. And so next I'm going to just talk about using those principles. We did this ICU relocation study. We did this study back in 2013 and 2014. We started early 2013, about 9 months before the hospital was relocated. So the background of this relocation is many old healthcare facilities are being replaced or refurbished around the world to accommodate the changing needs of healthcare services. For example, a lot of old buildings can't have those technology kind of requirements anymore. And also a lot of hospitals, or especially critical care, intensive care units, are adopting the single room design instead of the traditional shared room design. So the reason of that in the literature report is because there's a thinking about single room design can help to control infection. It's also better for patient safety and for noise control for intensive care, for example. However, there's a very limited research evidence available in the literature to help us how to guide this relocation process for our ICU, moving from a shared room to a single room design. And we couldn't find any information about what factors we should consider for a single room, when we move into a single room setting. And also transition from the old to new, as we discussed earlier, may cause stress and emotional strain to staff. So this the study site, the old site had 550 beds, and they actually had less. It wasn't that many commissioned actual beds. And had a 14-bed ICU and had a shared room structure. I'll show you some pictures in the next slide. And the new site had 750 beds, had about 20-bed, had a 20-bed ICU. The ICUs actually only had, at the time of the relocation, only 20 beds were commissioned by the government, but they actually have the capacity of 50 beds in this ICU. And they have opened up more since the relocation. And the whole new site uses single room structure in the ICU. And also they introduced new services, including pediatric ICU and cardiac thoracic surgery. So the ICU would receive patients who had heart surgery post-op in the new site. So this is a picture of the old site after the hospital was relocated. The room was empty. It's just quite incredible to look at it. Just one big open space with 14. They didn't have the whole 14 patients in this space. There's another little section they put patient with infectious disease. So this is a section for where the majority of the beds were. This one open space. And this is a picture of one of the new rooms they have in the new hospital. So you can see there's just one bed here, and between the rooms, this is the window, and the hospital has blinds on it. So for a short person, if you stand here, be able to see your patient, it's very hard to see. You're probably impossible to see the other patient in the other room. And the doors also quite separate from each other, so you can't really relieve each other or help each other. So the nurses can't really help each other in that environment. So this is the long corridor. The new ICU has 10 bed pods, so every 10 bed there's a one pod, And this is, one of the rooms, and this is the next room. So you can say it's kind of quite separate. The nurses, in every room, the nurses' chairs and stations inside the room. So it's kind of just structurally very different from that. So the aim of the study, so before the relocation, the hospital management, the ICU management team spoke to us saying they needed some help with managing the transition process. There were a lot of anxiety about people moving into single rooms and how everything works, and people getting quite stressed out. So we decided to identify what concerns people had and what had to change, and how we can address that. So to identify, develop, and implement some strategies, and then evaluate if these strategies have worked. So it's a 3-phase qualitative study. We went through an assessment phase, and then we implemented strategies, and then we evaluated how everything went. So we used the activity theory to support as a theoretical guide to help us to manage the transition process. And then we used the change laboratory method. The core of the change laboratory method is about expansive learning. So I won't bore you with this theory, but just quickly explain. The activity theory was from psychology, was firstly proposed by Vygotsky from Russia many years ago, and then Ian Eastrom from Finland translated this theory into English in 1987. So it's really just about looking at how people go about doing their daily activities. They need to use some tools, they will need to follow some rules, and then there was a division of labor in the hospitals. We all kind of have different roles to achieve the same outcome, which is patients get cured. That's the ultimate our aim. And then people get out of the hospital, come in, go through the process, and then they go home and safely. So in healthcare systems, there will be many activity systems interact. For example, the nurses' activity and doctors' activities, and the we hopefully we have a common shared objective to achieve the good outcomes for the patients. So the expansive learning cycle is just really about how we go through the quality improvement process in our clinical placement. It starts from questioning our practice, what concerns people, what have to change for this relocation, to analyzing what are the important things that we have to do, and then model a new solution. So modeling a new solution is quite important to get input from all staff. So not just the small group of management people doing it. You really need to let everyone know, we're doing this, and then we like input from all of you. And you have to have processes of collecting information from all staff. And then you need to test the new model and see how it might work. And you might need to revise it and make sure it would work. And then you implement the new model. And after a certain period of implementation, for our study, we did a monthly review of the implementation strategies. And then you reflect on the model and see if everything's working well, if any further improvement needs to be made. And then you consolidate. So this is a new way of doing things, and let's continue. And the expansive learning cycle really, it considers this cycle a upward spiral cycle. It's not a closed circle, kind of a round. So your clinical practice improves every time you go through this cycle. So the first phase, what we did was we kind of wanted to know what was the main concerns from staff, and to identify what changes have to be kind of looked at for the relocation. So we invited all staff, including doctors, nurses, allied health staff, and support staff, to participate in focus group interviews and individual interviews. So we had 55 participants who signed up to participate in 12 focus groups. So we couldn't do large focus groups up to 8, like what we think. Most of the focus groups had about 4 or 5 people, because everyone's so busy at work, we couldn't get people off the floor. And we also had 8 individual interviews with some key people in the ICU relocation management from the ICU and from outside ICU, and also for some staff members who either didn't have time, couldn't participate in the focus groups, or they didn't want to be part of a focus group. So they had other things to say. They don't want other people to hear. So we had all that. So we analyzed this data, and what we found was most of the anxiety was kind of related to working in single rooms. So people were not sure, what has to change, how everything's going to work. So that causes a lot of anxiety. And the patient safety was the main concern. So if patients are going to be safe, there were concerns about patients might fall out of bed more often. We might use more sedation because we don't get, it's difficult when you don't get the help you need. You might sedate patients more. You may use restraints more. So there's a lot of concerns with that. And there's also concerns about communication, teamwork, about how the team is going to work. In a shared room model, it's kind of quite, think about it's more convenient. You can get the person looking after the patient next to you to watch your patient when you need to go and get something. But in a single room model, in that particular setup, that won't happen. That would be impossible. So how are you going to deal with that? And then how are you going to get help? Like, are you going to call people? Is it going to be phones, whatever? So that was all quite unclear at that stage. And then also work processes related to the single rooms, for example, how you respond to emergency kind of situations, and then how bedside nurses get help, what's the patient turnaround, how that happens. So there's a lot of concerns that basically falls into the 4 categories. So after that, we started planning for the implementation. So we introduced a research assistant. We didn't call it change champions. We thought if we tell people, this is your change champion, that really scares people, and it gives the person a lot of pressure as well. So we recruited a staff member who were not full-time to work for the project a couple of days a week, and the person was based in the ICU. Being a normal staff member, so she was already part of the team. And we also established a single room work process of working party to really look at what has to change and what processes we have to plan for. So the research assistant was the lead for the single room work process. This research assistant, she was just before this, she was just a bedside nurse. She was not an educator or manager or whatever. So, but she has a really good interpersonal skills, and she was really interested in leading this process. So that was what we introduced first, and then we looked at improved communication. So before this, there was a lot of issues with people not getting information. There was a lot of rumors going on about parking being very expensive and all those things. So we introduced a regular newsletter dedicated to the ICU relocation, and we made sure the research assistant was in the unit for a number of times a week. She split her 8 hours into 2 days. Kind of, she was there more often, and we also took meeting minutes and disseminated to staff, and we gathered people's home email address so people can get the information from work, or they can check the emails at home. And then we printed hard copies, and they were available in the tea rooms, and they were given to the nurses at the bedside. We also collected frequently asked questions, so and then provided answers to those, so people know someone have already asked this question and this is the answers. We also did a social networking survey, so I'll show you what we did. So if you think about at work, and quite often, we don't get the information from where you're supposed to get it. You will go after the people who you like to ask. So sometimes the social networking survey, it's kind of tells you where people get the information, and that can help you to disseminate the information. And we also did some pre-move simulations. So we did a single room simulation, asked people to draw curtains between the beds in the open shared room setting, and then to pretend that they could not talk to each other, just have a sense of how they feel. And it didn't work very well because people couldn't stand it, not being able to get help from the person next door. And also we modeled the meal relief patterns, because in the shared room model, quite often the nurses next to each other could share, interrelieve, but in a single room setting they couldn't. So we looked at that and looked at the staffing levels for that period of time for meal breaks. And also we revisited the access nurse rounding model. So this hospital has a nurse's position as access nurses. They don't get extra money for this title, but they kind of it's an upskill kind of thing, another level of employment, but doesn't attract any extra money, if that makes sense. So we reviewed that. I'll show you in the next slide. And then we also looked at the clarification of roles and looked at if nurses were doing anything that's non-nursing. For example, the nurses in the open room setting, they had to move the rubbish from the bedside to an area where environmental services will collect those bags. So we'll look at those things as well. So this is a social networking survey. So it's a 6-item questionnaire. People were asked to rank 3 people they prefer to get information from. So the first question we asked them, who do you think has information about relocation? And then if you can see this graph here, we had to de-identify everybody, so give everyone a code. So you can see A18, A38, and B50 all quite big. And then you can see B57 is much smaller. So people didn't think not a lot of people thought that person had information. But if you look at the next slide, who do you like to go to for information? So this is about where they prefer to get information from. And you can see A18 is still quite big, but B57 it become bigger comparatively. So what we did was, because this information is all originally identifiable, so it was only me, I was the only person knew who B57 was. And then when we established a single room working party, we purposefully approached that person, and that person was a part of that working party, and that person was in the loop, the communication loop. So the information gets implemented. It was quite time consuming to do this social networking survey, because people felt quite intrusive, because you have to really name the people with real names. But it was really helpful with that. And also in the newsletters, we looked at to communicate what we found. So from the first phase, after that, we put all the information in a newsletter. And then also we asked people, what do you think we have to do as a team to go through this transition together smoothly? And the people had a really good, I can see questions popping up. I will probably answer them in the end. Patient safety is the most important factor. Feeling uncomfortable is okay. And even with a well-planned move, there will be unpredictability. And you have to be willing to communicate with your team, and to solve new challenges, you have to actively seek information. So before that, a lot of staff saying, there's no information, but there was some information. Some people just either didn't know where to look, or just was too busy to look for it. So we clearly telling people, if you want to be part of this relocation, go through transition smoothly, you have to take responsibility. You seek information, you ask questions. And we, people saying we are relocating together, so we all have a role to play in the learning process. So we did this regular newsletter regularly. The access rounding model, this is the access needs assistance, coordination, contingency, education, supervision and support. So through reviewing, when we compared with the shared room model and the single room model, we look at some aspects of the access nurse's role going to change. So, it seemed like the access nurses would have more responsibility in education, supervision, and support when it comes to single rooms, because the staff was all isolated in the rooms. The access nurses are the ones, the bedside nurses are first port of call, basically. So we were looking at previously access nurses were just supporting staff as with the procedures and meal reliefs and all that. So there's going to be a role change for that as well. And we created this access nurse rounding tool for them to kind of learn how to plan. Once you're in a single room environment, So you've got to think about, who you got allocated. Every access nurse at that time probably would be responsible for 4 to 6 nurses that on your shift. You got to support. That's your team. Got to support them. And then we got this tool, basically ask them at the beginning of the shift and think about which staff in which room might need a little bit of supervision, might need a little extra support because this person's new, and then kind of plan their day activities, because the day can go so fast when it gets busy in ICU, and you can say, oh my God, 6 hours passed and I haven't been to that room. That poor girl's just really new. So this kind of helped them, and we used this for a while, and eventually the access nurses felt like, we don't need this anymore, and then we kind of learned how to plan it. So we didn't kind of continuously to use it. Post-move, after we moved into the new location, we started monitoring and reviewing post-move issues. We planned all those things, access nurses, surrounding model, we planned for meal relief, planned to, how to support nurses at the bedside, what the experience is like when they move in. So we created a post-bedside nurses survey, which includes the things like if you are able to carry out patient care as much as you liked and at the time you needed, and did you get urgent help when you needed, and with drug, medication checks, whatever. So we asked the nurses to complete this survey at the end of this shift for a 3-month period after they moved in, so to kind of understand how things are working. And we analyzed those, we looked at those things periodically while we were still collecting feedback from nurses. We also did some follow-up interviews with nurses. For example, even the nurse saying, I noticed some of the medications were not checked, it was given to the patient, and we followed up with those, and the staff say, yes, there's some normal saline flushes we checked at the handover, but it wasn't checked again before I flushed the patient's line, for example. So we did those things and clarified those issues. We also monitored the meal relief, so look at if people were able to go and have their meal, lunch and dinner, on time, or if the meal breaks got interrupted very often due to the work demands. And we also looked at how staff get assist. I'll talk about this in the next slide. And staffing levels and the new services that was introduced were all kind of being monitored and planned. The access nurses rounding model got further reviewed through this post-move process. So we looked, had discussions with the management team, look at, these access nurses will need to, we will need to look at further recruitment criteria, because these people will need to provide more education, supervision, and leadership support to nurses at the bedside. And we introduced the mobile stock trolleys, so nurses in the single rooms can stock up their own areas, and then we looked through what has to be, that we use so much stuff in ICU. So we look at through what needs to be on those trolleys. So we, had meetings with staff. What do you want to be on the mobile stock trolleys, and then how much do we need on it, and how much stock do we need in each room? So we look at those things, and we also did further role clarifications. From that, after the move, the cleaners, called environmental services, they started doing rounds to check every rooms and emptying those rubbish bins kind of regularly. And also the wardsmen started, that they have, I don't know, even other hospitals in Australia also call them wardsmen or orderlies, the people come in to help you with patient care. So they would come to do, we had dedicated those people for ICU, and they started doing regular rounds together with access nurses, so that kind of works through the system. And this is the staff assist button I talked to you about. I like to talk to you about. Previously in the shed room model, nurses often just kind of sing out and ask for, I need some help here, because people can hear them. But after they moved, the access nurses, all access nurses had a phone, had a kind of a hospital communication phone in their pocket. So a lot of staff preferred to call the person instead of using the staff assist button, because this didn't exist in the previous environment. And the people some people thought this was for emergencies, so they wouldn't use it. So that when we spoke to the access nurse staff, the access nurses kind of, they're saying, I'm just really busy, I get calls all the time. don't have time to cover everybody at one given time. Anyway, so we had a number of meetings with people, and then we wrote in the next newsletter. We had a newsletter basically explicitly tell people you need to use the staff assist button instead of phone for assistance. And then if you use the button, more people will hear it, and whoever is free, whoever hasn't got a patient load, see that, and then they can come and help you. And we explicitly tell them that this button is for you to get help. It's not for emergencies. And also we looked at how to create that environment to reinforce this behavior. So we told access nurses, if they call you, you tell them, go and press the button, someone will come help you, I'm busy. And then also to kind of encourage the use of discourage the use of bedside phones and to use the button to get help. And we also spoke to the staff who normally don't have patient loads. So if you hear someone press the staff assist button, and you got to go and answer it. So people kind of gradually see, okay, if I press the button, then I get help quickly. And that fact, the change didn't take very long. It took about a couple of weeks to see that change. So this is just a number of examples of a number of things we did. And then after 6 months after the hospital was relocated, we did evaluation. So we wanted to talk to people again about how we went with the research project and how we helped them. And then so we did the same thing again, focus groups and interviews. We had 5 focus groups this time, and I had 4 individual interviews. And in the single room setting, it was so hard to get people to come out, and we had to cancel focus groups so many times. Kind of, even as a researcher, I could see this challenge to working in a single room setting, with the staffing and all that. So regarding to effectiveness, staff told us the study helped the transition management process. So some of the management team members said ICU, because the whole hospital ICU is the only department that had this research project. So the ICU came through the relocation a lot better shape, maybe because of the research project. The newsletters really helped to improve communication and deliver some clear messages, and the people can get factual information from here. So that stopped the rumors and all that. And also the access nurse rounding model got reviewed, so that was really helpful. Staff assist button use behavior change was a really positive thing. And also the research team provided change management support to the nursing management staff. And from that, we talk about where we go from there. What's the next step for the working in a new environment. So people talk about they still want to continue with this communication strategy. The newsletter was well liked. Everyone wanted to keep it. So we did ask people in this evaluation what you want to be in there. People talk about we need to have new staff information in it, social things and new services, new equipment, all those things to use this newsletter for. How to improve social interaction among staff was kind of mentioned by a lot of people, because after the single room setting, you kind of very rarely to see each other. You only see the people who went on the meal breaks at the same time as you. Some people staff say, I haven't seen so and so for 2 weeks, even though we worked the same shifts. So that's something we needed to consider about how to address this issue. And we needed to continue to monitor work processes and make improvements, kind of look at how things work, and gradually kind of go through that peeping process. It takes a very long time. And the access nurse role development was mentioned about with future recruitment, we need to look at the role kind of selection criteria. And the emergency processes need to be further reviewed. There was also a problem with at the time about the emergency buzzer where it was located. I'll just show you. I'll go back a few slides. If I can show you, this is the patient's bed or the patient head, and this is where the patient head will be, and then this is the emergency buzzer. So, and the nurse's chair, I think, was somewhere here. So if the patient kind of, I think the nurse's chair is over there. So if the patients try to pull the tube, whatever, your natural response would be Thank you very much. You're helping me with the error. So it would be to hold the patient, and then you won't be reach that button. So that's something was being discussed at that time. And this staff education became a challenge because in the old days, the staff could, the staff looking after patients next to each other could really interrelieve. So you can send more staff to in-services, but with a single room setting, it's really difficult. So, the educators started looking at more creative ways of delivering staff education, for example, online modules and interactive online modules, and also online lectures and all those things. And the lessons we learned is single rooms have a lot of advantages. Patient privacy. The patient actually was really happy. The patient satisfaction survey revealed that they were a lot happier. There was a reduced noise and a better privacy, and reduced the number of complaints received from patients. And there's less interruptions for doctors for the morning rounds, and because they're in the room and people can't just come grab them and ask them a question. And there was also less accidental extubations. I don't have the actual data for that. I just had a kind of a quick chat with them, asked them about these quick numbers. That's what they told me. And I think the main lessons we learned is about this whole change management project is the team wanted help and wanted to do this properly together. And then this was the idea from the management team saying, let's do a project and how to manage this. And then the clinicians, the change champion and all staff, they were the drivers. And as researchers, we were their support. If they tell us they want to fix this, and we go and go to literature, find strategies and make recommendations to them. And they're the ones actually in the end that make decisions what to do with, every that. So that's probably what we really, what we learned. So this is some of the quotes from the participants. Oh, something has disappeared. The post-move bedside nurses survey gave me reassurance that someone was monitoring what we were going through. It was difficult moving into a new environment. And then people talk about, the Fox group helped me to think about the relocation and forced me to face my fears about moving into an isolating environment and do something about it. And going through the research process was helpful for me to think about my own work and how I would make future changes and stimulate my own ideas and thoughts. So take-home messages from today's talk, I think it's one thing about when you're managing change, you think about it systematically, make sure you cover all crucial aspects. Think about donor obedience, structure, process, and outcome structure. Involve everybody. Communicate. So make sure you communicate with people, and then make sure people get the information, and make sure you have the communication loop going on, so that it's just not one-way communication, it's two-way communication. And give people feedback. That also everyone, including the management team and the staff, need to be open-minded and be flexible about the unpredictable. Moving into relocating from a shared room model to a single room model, depending on your actual structure differences, there's really a lot of things you can't predict. So you have to go through that. And hopefully, I think, with more hospitals relocate and more research projects come out, and we would learn a lot more from each other, then we can kind of manage it in an easier way. And make sure once you move into the new environment, you monitor the progress and revise your strategies if necessary. And most importantly, you monitor your patient outcomes and make sure patients are safe. Also, staff are safe in those environments. So that's my references. And we have a couple of papers planned from this study. We presented the research at a couple of conferences already. This paper is the report of the first phase of the study, which has just been accepted by Australian Critical Care a couple of weeks ago. And so we acknowledge the Gold Coast Health Institute, and now it's called the Menzies Health Institute of Queensland, and the Gold Coast Hospital Foundation Collaborative Grant in 2012. ACCCN also provided a research grant, and these grants all was really important for us to have the change champion to be based in the ICU. We thank the hospital and the staff for their support, and also importantly my research team members who worked so closely on this project. I've established the ICU relocation discussion group on LinkedIn. Not much happening there, but whenever I come across any information, I would share in that kind of group. So you're more than welcome to go and find it and join the group yourself. And that's my email if you have any questions, and you can email me. So that's all from me today. Thank you. Any questions? I'm just looking at reading these questions. Okay, just give me a minute and go through that. Yeah, so Dai just said, Anthony asked question, was 3 months long enough time? Yeah, is this about the post-move? No, I don't think it was long enough. I think we started the project 9 months before the relocation, and that we felt really, probably we should have started the project at least 2 years before, before they actually relocated, so we could start the planning together with staff. So the start of the project really late, and post-move, because we have the funding restrictions, so we had to conclude the project at a certain time period. So we had to do evaluation quite early. We wish we could have kind of waited for another 3 months to do evaluation. So that's what we felt. We wish that there was a longer time.
Can you hear me, Francis?
Yeah, I can.
Oh, it's Anthony here.
Yeah.
I was actually stating that the 3 month period was actually where we implemented our new nursing model within the old unit before we decanted and commissioned the new unit.
Yeah.
So yeah, I would certainly agree. 3 months was by no means a long enough period, and I was pushing very hard to, in fact, try and make it a minimum of a 6-month trial period of the new nursing model in the old unit by doing things like keeping the curtains closed and keeping staff a little bit more separate from each other, as they would have, as they now are in the new unit. And as I've said in my little rant there about our move, 6 months certainly would have been my preferred trial period, but I don't even think that would have been a long enough period. Our change management program in itself was, as you just stated, it was a good 2-year process in going through the program of what we're doing now as opposed to what we're going to do in the future. And that's the change model that we sort of used. But the redevelopment is, as you would well know from Gold Coast University Hospital and the whole redevelopment there, from start to finish, is a good 4 or 5 year program.
That's it. Yeah.
We're also in a regional area here, and like I said in my statement, we're not in a position where we can just call on agency staff to help out with us as well. So we had to interview every single staff member and find out what their preference was, because obviously we couldn't dictate. Originally being a combined unit going to a separate ICU and a separate CCU, we weren't in a position to dictate, okay, well, you're going to ICU and you're going to CCU, and that's that. So we had to interview every single staff member and ask what their preferences were. And as I said, we had staff that in the combined unit, it was a lot easier to allocate, because we knew who had the cardiac skills, we knew who had the ICU skills, and who could ventilate, who could look after renal replacement therapy and vasopressor therapies and infusions and so on and so forth. So we were on an absolutely massive learning tangent and a professional development stream like I had never been involved in before. So it was, I mean, it was quite overwhelming at times, as I'm sure your experience was as well. But at the end of the day, you know, we do these things to the benefit of our communities and our patients. And I've got to say, and I'm sure you would say too, I'm very, very proud of the outcome and what we've managed to achieve.
Great. You know, it sounds like you've done a really good job with the process, like involving staff and really listen to what staff, what they want to say. That's just really important. What we found, communication was probably one of the key things. We looked at through the whole process of that. I think communication really is something really helped with the whole project.
Yeah,
you should probably
absolutely.
think about publishing your experience, because we really need evidence from clinicians about what strategies they used and how that worked.
I actually hadn't thought about publishing it. No, I've certainly kept a diary of the experiences. And I've kept very in-depth records of the learning programs and the processes that we went through over the especially the preceding 18 months to commissioning of the new units. But I might actually just do so now that you've mentioned it.
Yeah, you should. You should. I think we really do need some more evidence about, because every single room setting is different. Every change relocation is quite, you have your different things, and how you kind of dealt with that. It's really important. Yeah.
Yeah, and I mean, especially within different health districts as well. I mean, Queensland Health, would have provided you with very different resources than what New South Wales Health would have provided us with, both in terms of infrastructure and in terms of FF&E funding and that sort of thing. So I mean, as we all know, the resources are a very finite thing. And every time we would have meetings with health infrastructure, we would find that there would be another $10,000 suddenly knocked off here and there. And so our plans would have to change again. So I don't know if you had that sort of experience either.
I think with this hospital relocation, for starters, the relocation date got pushed and pushed.
Yeah.
At some stage, the hospital was supposed to be relocating in a few weeks, and the people still didn't know if they were actually going to do it.
Yeah.
That really kind of contributed to the anxiety and a lot of kind of negative attitudes. So it's difficult with change. There's so much stuff that's unpredictable and so many factors you have to consider.
Yeah.
So we really do need more evidence on how well we do things. I see your one of your comments saying about the emergency buttons. So in the end, what we did was, you couldn't really rewire it or whatever. That's where the emergency button is located. So we had to just tell people, your first thing you should do when anything happens is you need to get help first. So you need to go and press the button and then go to the patient. It's still very difficult. People still do go to patients first and they sing out.
Yeah.
But you just hope if that happens, the person next door will hear them.
Yeah.
I haven't spoken to them again recently, but they were looking at that closely about how to make sure patients are safe and the staff are safe and they can get help properly. Yeah.
Actually, it's funny that you should raise that point again. That was one of the when we initially moved in, the IT people had not realised that that they were required to make each call a different sound. So the patient call bell, the nurse assist button, and the emergency button all made the same noise.
Oh, okay.
When we first moved into the unit, and this was despite the fact that we actually did pre-commissioning testing And when we did the pre-commissioning testing about 6 weeks before the move, everything was working fine. But then some bright spark in IT, pardon the pun, thought that it was a better idea that they all sounded the same. So went and reprogrammed them all so that everything sounded the same. So our first 2 weeks we had to be, extremely hyper vigilant about any call that went out, because it took them 2 weeks to actually fix the problem. And the hospital and Ministry of Health down here just were not prepared to put the move off any longer. So
Yeah,
it was a fun first 2 weeks.
Well, that's great talking to you, Anthony. Thanks for sharing that experience. Are you in my ICU relocation discussion group at the moment?
I'm not, but I am on LinkedIn, so I will certainly hop on and have a look.
Yeah, that would be great. And most of the members in that group, they are going through relocation at some stage. So it would be great to, if you have anything you want to share, and feel free, and that'll be great.
Yep, excellent.